Good morning, everyone. I am Associate Professor Dr. Tiong Win. I am from Myanmar. I came to Malaysia since 2002, so already 22 years. I am teaching medical students. First of all, 8 years in UNIMAS, University Malaysia Sarawak in Kuching. Now, after that, I moved here since 2010. So already here about 12 years plus, 10 to 14. Nearly 14 years already. Now I am going to show how to do abdominal examination today. For that, I have requested my student here, his year 3 students, MBBS, under University of Kuala Lumpur, Royal College of Medicine, Perak. He obliged, so I am going to demonstrate upon him. Okay, first of all, regarding abdominal examination, every student should understand about 3 steps. That is the approach to the patient. First 3 steps is assume the patient like your own relative and approach them humbly down to earth. And then deal with them friendly manner and smiling face so that the patient will love you, will like you. Next 3 steps is you are all ready to examine the patient. So first point is observe privacy. So we have to cover up the screen, be with the chaperone, especially opposite sex. Male examining female, be with the chaperone. Female also examining male, be with the chaperone. After that, adequate exposure and appropriate position. So today we are going to examine upon a shape during the supine position. Although it is adequate exposure is from nipple level up to mid-thigh, but because of modesty problems, so we are going to expose just the abdominal part only, and I'm going to demonstrate on that. Okay, now after that, 6 steps is in Auscultation exam. In Auscultation exam, first step, the examiner has to introduce himself or herself. I will do that. Now I'm going to introduce, I've already introduced already. Now, next one is greeting the patient. Okay, greeting the patient. So your name, I know, Mr. Shafi. You are 23 years old. Okay, so today we are going to demonstrate. Now I'm going to do explanation. So abdominal examination. So 4th step is to get the bubble concept. Will it be okay if I do abdominal examination upon you? Yes. Okay, so I got the bubble concept. Number 5 is reassurance. Okay, this program is not anything. But for example, like if we do PI examination, anti-tube insertion, something like this, a little bit uncomfortable is there. So that patient has to be reassured that, so I'm going to do it quickly and gently so that I'm not going to hurt you. But final step, number 6 is, once I finish every step, I will thank to my patient, to my examiner and go up. That's all the 6 steps. Now, I'm going to start. Okay, please lie down. So take out your button. Okay, release a little bit. Okay, sit up again. Sit up, okay. First step to do abdominal examination, I have to do general examination. Before that, I have to take the history taking, and after that, I'm going to do clinical examination. That is abdominal examination I'm going to demonstrate today. So for that, I'm going to do general examination. Now I'm not going to talk detail about general examination. It's already another instructions we had. So already done general examination like hands and then the eyes and then the other areas, something like that. So assuming that done already, okay, please lie down. Now he's resting at the supine position. Now exposure, although nipple to mid-thigh, I'm going to expose abdominal part only, a little bit, that's all. So first one, I have to exclude. To observe during inspection, I have to stand at the foot end of the bed of the patient, and then I will look the abdomen whether it's moving with respiration or not. If not moving, the patient may have acute abdominal condition, but is moving here. Now, assuming that, I will assume 2 conditions for this. Now, first one is pain at the right iliac fossa, assuming that acute appendicitis. I will do. Next one, Assuming that patient has acute cholecystitis, I will examine. Okay. Now, assuming that there is the acute appendicitis, because it is not complicated, just acute only. That's why still he can stand. So the abdomen is moving with respiration. So after that, from inspection from foot end, now I'm going to sit down. So by sitting down, my height of the chair, it has to be appropriate. So when I'm going to palpate with my hands, so it is going to be flat, four all fingers like this, and then I'm going to palpate. Now, before that, now I'm going to do inspection. During inspection, I will look at his abdomen. First one is umbilicus is centrally located and inverted. Afterwards, I'm going to look for any scars present. About the scars, there are so many. I will just detect all the scars. So, midline incision, upper, lower, right paramedian incision, left paramedian incision, or rooftop incision below the costal margin. And Mercedes-Benz incision is for liver transplant and so on. We are going to do Mercedes-Benz shape. This one is sternotomy, subcostal, so that it looks like Mercedes-Benz. That's called scar. Another one, if it is at the McBurney's point for appendix operation, lance incision or cretinine incision. Another one here, we have the skin crease here at the lower part of the abdomen. We call it phanencial incision. So these are all. Another one, Morrison's incision is subcostal or coccus incision as well for cholecystectomy. Okay, that's all for the scar. So look at the scar, there were none. So if there is a scar, we have to measure the length of the scar as well as does it look like well-healed scar or hypertrophic scar or keloidal scar, something like that. Or afterwards, now I'm going to look at any possibility of the swelling. So in one area and under the incision. So after observing any abnormalities apart from these, are there any ulcers or eczema or any visible swelling and so on? Now, if it is a trauma case, there are wounds and so on. Okay, now with that inspection, after inspection and reveal already, I'm going to ask, okay, Shafiq, please turn your neck to the other side and cough. Okay, that's all enough. So when he's coughing, I will look at possibility of appearance of swelling. That's, we call it, okay, visible cough impulse. There, I'm going to pay attention either under the scar or around the inguinal area. If there is visible cough impulse, either it's a direct inguinal hernia or indirect inguinal hernia or femoral hernia or incisional hernia, I can identify. After this, another test is Carnes test. Okay, put both palm on your chest. Okay, by now he has to either raise the head or raise two lower limbs, knees straight. Okay, do that. Okay, enough. Thank you. So this is called Carnes test, where we will see appearance of any swelling. So inspection done already. Now I am going to palpate. Now we have 9 quadrants of the abdomen. Those are by using two lines. Here mid-clavicular line, left and right. Here transpyloric, transiliac crest. So these 2 lines. Within these 4 lines, we have 9 quadrants already. Right hypochondrium, epigastrium, left hypochondrium, left loin or left lumbar, umbilical region, and right line or right lumbar. Right iliac fossa, suprapubic or hypogastrium, and then left iliac fossa. So these are 9. But assume that this patient came with pain at the right iliac fossa. So I'm going to pay attention to that. For that, we have to start palpating from the opposite quadrant. This is left hypochondrium. So first palpation is soft palpation. So I use all my 4 fingers here flat on the abdominal wall, and then just simply 2 centimeter depth I palpate. After that, left loin. After that, right left iliac fossa, after that suprapubic area, umbilical area, epigastrium, right hypochondrium, right loin, and then right iliac fossa. By now, once I'm feeling at the complaint site, I have to feel for are there any guarding. If it's guarding, there is guarding positive. Next, any tenderness, there may be mild tenderness. This is for soft palpation. Now, I'm going to do deep palpation. For that, I have to stand up and keep two hands, little bit angulation. Now, here I'm going to do 4 centimeter depth. So with that, I'm going to palpate here 4 centimeter depth. Just to exclude any another problem. So something like all the 9 quadrants I'm going to do. But here, only I am going to pay attention. There with the deep palpation, first of all, observe guarding. Next, tenderness and deep tenderness. One, they are positive as well. Now I'm going to test for the rebound tenderness. Okay, suddenly I release the left hand first. After that, once on releasing that, are there any pain? So if, first of all, appendicitis starts in the lumen of the appendix, that is called visceral pain, slowly spread to all the 4 layers and irritating the parietal peritoneum already. By that time, patient may complain, first pain from umbilical region around to shifted to right iliac fossa. By that time, if parietal membrane already irritated, once I do rebound tenderness, it will be positive. That's me. Once I press, it's curved. Suddenly release, it's straightened again. By that time, if peritoneal membrane already irritated, patient may complain of pain already. Done. Now, for the appendix, apart from these, I will do few tests already. First test is psoas test. Psoas test means, now I'm going to press his right knee. Okay, Shafiq, please try to raise up your right knee. Okay, now he's doing that. Okay, enough. That means he's contracting his psoas muscle behind the cecum. If his appendix is retrocecal type, he may complain of pain. That means psoas test is positive. And we know the position as well. Another one, okay. Right angle, okay. By right angle, bending the knee and hip, I am going to turn lateralwards. So now he's making his hip joint medial rotation. By that time, he's contracting his obturator muscle already. If he is painful, this obturator test is positive, meaning the appendix is pelvis type. Okay, these are 2 tests. Another one, what I'm going to do is press at the left iliac fossa. If he complains of pain at the right iliac fossa, that means this is Robson sign. As I press here, the shifting intestine irritate the inflamed appendix. So that Robson sign is going to be positive. Okay, that's all. But when you are palpating, mind you, apart from these, guarding, tenderness, deep tenderness, rebound tenderness, apart from that, if patient has perforated appendicitis or peritonitis sets in already, on examination there may be rigidity as well as distension, and generally there may be toxic signs as well, high fever, okay, all the other signs, the vital signs may be changing. So that's all for appendix. Now, I'm going to demonstrate upon acute cholecystitis how we do Murphy sign. Okay, for that, whenever we are going to palpate for liver as well, start from the right iliac fossa, and then this radial border of the index finger parallel to subcostal margin. That's how I'm going to palpate for liver enlargement. Now, for the acute cholecystitis, we have to elicit Murphy sign. How are we going to elicit Murphy sign? Okay, Shafiq, please breathe in deeply and then out. Okay, after that, okay, I'm going to press. Breathe in deeply again. Now, okay, done. So by that time, if there is pain, if he wins or if he stops his breathing, that means Murphy sign is positive. For that, Murphy sign is not only by examination, by the radiologist if they are doing ultrasound examination. If they keep the probe here also, they can elicit. So that's called sonographic Murphy sign. Okay, done. Now, I'm going to show you how we are going to do liver palpation. For that, I'm going to start from right iliac fossa, slowly step by step coming up. But if you think that patient may have enlarged liver, definitely you start from here. And once you can feel, you just mention, okay, below the subcostal margin, how many fingers breadth the liver is enlarged. But Mr. Shafiq is the one I have chosen, and he obliged because he's the one having this liver mildly palpable here. It was the normal. Okay, can you please angkat kaki? Okay, raise your knee both sides. Raise your knee both sides. By now, abdomen is more relaxed. So by now, I'm going to palpate his lower bora of the liver. Okay, breathe in. Yes, now I can feel about 1 finger breadth. This is normal. His condition is nothing, not because of that. No tenderness and so on. I can feel 1 finger breadth below costal margin. That is the enlarged liver. Now he is breathing in, okay, out and in. Now I can feel his liver edge already. This is his normal. So that is for liver palpation. And now, okay, bring down. Another one I'm going to palpate for spleen. So also we start from the right iliac fossa, but by now fingers are pointing towards the left hypochondrium. So here slowly come up. So if he has splenic enlargement, there are 5 clinical signs. Those are, I can feel the notch with the enlarged spleen. Another one, I cannot insinuate if there is enlarged spleen, in between enlarged spleen and then the subcostal margin, cannot insinuate. Number 2. Number 3, now I'm going to show you. Here I'm going to palpate. This is first rib, second rib, third rib, fourth rib, fifth rib. This is the sixth rib. Sixth rib is lower bora here, and this is subcostal margin. Sixth rib, subcostal margin, and here mid-axillary line. This area is called trough space. Traude. Trough space, I will percuss. Now, still resonant. That's why he has no enlarged spleen. So after that, just now I told you, enlarged spleen has got characteristic features of having notch, cannot insinuate in between subcostal margin and enlarged spleen, and the spleen move with respiration. Number 4, trough space is dull already, no more resonant. And if you percuss, the dullness over that trough space and dullness over the enlarged spleen in the abdomen as well, continuous. These are 5 signs of enlarged spleen. Now I am going to demonstrate kidney palpation. So that kidney I am going to palpate with my right hand in front and left hand behind. Okay, for that I would like to show you. Okay, sit up. Now I am going to show you how we do. There's a renal angle, palpation of renal angle. Now this is the 12th rib, lower bora of the 12th rib, and this is the paravertebral muscle or erector spinae muscle. So here, in between this lower bora of the 12th rib and then the lateral bora of erector spinae, this is the renal angle. Now I'm going to show you how I do renal punch. 4 ways to do. This is the one method. Another method is I will use soft pad here, another way. This is another punch, 3 already. So I will keep left fingers underneath and punch. These are 4 ways to do punching. Similarly on the left side as well, lower bora of the 12th rib, lateral bora of the erector spinae muscle. Okay, done. Thank you. Lie down again. Now I'm going to palpate his kidney. Okay, now this is the right hand in front, left hand behind. Now I'm around the right renal angle. So I'm going to do this palpability. So ballotability means synchronous this way, so that I'm trying to ballot. If there is kidney enlargement, I will be able to feel it, enlargement of the right kidney as well as ballotability. For the left kidney, the same thing. Same, my right hand in front, left hand behind. And then I will feel and then ballotability. Okay. Now how we are going to differentiate in between enlarged spleen and enlarged left kidney. So here I have spoken 5 characteristic features of enlarged spleen. Now enlarged kidney, there are 4 characteristic features. Here being enlarged kidney, I can feel enlargement and is ballotable, number 2. Number 3, I can insinuate in between enlarged left kidney and subcostal margin, I can insinuate. Number 4, the kidney may not move with respiration. So these are all 4 characteristic features. So I have done liver palpation, spleen palpation and kidney palpation already. Now any time if we can feel any mass, for example cancer stomach here or sigmoid colon cancer here, when I am going to palpate for that lump, so there are characteristic features you have to mention. So number 1 is site. Where is size? How big it is? The breadth and then the length, whatever. Site shape. Is it rounded, oval or oblong shape? Surface. Is it smooth or irregular or nodular? Consistency, firm or hard or cystic? Mobility. Is it mobile side to side, up and down? Fixity. Either it is fixed anteriorly to the skin, you have to pinch the skin, whether it is attached to the skin or not. That's all. So sigmoid colon as well. This is characteristic features of the lump. Now, I'm going to another step, that is percussion. Percussion, here, I'm going to keep my middle finger of left fingers, it has to spread a little bit. And now I'm going to percuss with my right hand. That means my right wrist is going to walk like a hammer. So wrist walk only, not from the elbow. So here I'm going to percuss. By that time, 2 fingers here, 4th and 5th are flexing and partially flexing my index and thumb is like that. With that position, I'm going to percuss with the right middle finger to the middle phalanx of the left middle finger. Now I'm going to percuss. Come nearer. I'm going to test shifting dullness. Now dull already. So this dullness is not because of the fluid, intraperitoneal fluid, just because of the muscle bulk here at the loin. Okay, I will ask him, okay, turn to the left. Okay. Now I will fix my finger here. I cannot move my fingers. So keep about 1-2 minutes. After that, so that is the same area. Now I'm going to percuss. Now dullness is maintained. If there is fluid intraperitoneally, once the fluid shifted to the left side, I can get the resonance here already. That is testing the shifting dullness. Okay. Same thing. We can test on the left side also. Yeah, shifting dullness. At the same time, if there is ascites also, I can do something like thrill. We can see distended abdomen with the fluid inside. If I tap here, there may be fluid trail. Now here is none. So I can ask the patient to keep his, okay, and then I can tap and see the other side as well. There's fluid trail. Okay, done already. Now, other percussion that I'm going to try to do is liver span. So here is the clavicle, here is the sternal angle, here is the second rib, this is third rib, this is fourth rib, this is fifth rib, this is 6, 7, 8, 9 costal cartilage. Okay, now I'm going to percuss here. These are all resonant. Up to 5th intercostal space. Now 6th intercostal space. Dull already. Dull. So along the mid-clavicular line, the dullness is starting from here up to here. This is the liver span. Okay, just now I show you trough space, resonance and dullness already. Instead of liver dullness is here, if disappearing, liver dullness disappearing, I can have resonance here already. Shafiq, what does it mean? What is the diagnosis? If liver dullness is obliterated, what is the problem intraperitoneally? To give rise to pneumoperitoneum, to give rise to air leak from the duodenum. So what does it mean? What disease that you are going to have? Duodenal ulcer perforation. Understand? If duodenal ulcer or gastric ulcer perforate, there may be gas leakage intraperitoneally. Thus we call it pneumoperitoneum. By that time, when I percuss, this liver dullness may be obliterated. No more dullness. It may turn out to be resonant already because the leaking air may be occupying in between anterior chest wall and over the surface of the liver. At the same time, if we take erect chest X-ray as well, we will see gas under diaphragm shadow. Okay, that's all. So for the time being now here, percussion already shown you. Now, auscultation. Sorry, today I forgot to ask you to bring the stethoscope. It's okay. With the stethoscope, we better hold between the bell and funnel. So with 3 fingers, and we have to listen. For the intestinal sound, below and lateral to the umbilicus, we can listen. There may be intestinal sound here as well. Normally, anyone can listen Ohm's intestinal sound with stethoscope. That's all. Another one, apart from intestinal sound, we can listen to renal bruit. So here we have zip pipe process and then the umbilicus midway about 3 centimeters laterally. We can keep the funnel here and then listen. If you can hear a little bit trill and bruit, that's called renal bruit because of the renal artery stenosis. That is for right side. On the left side, that is for the left renal bruit, if there is renal artery stenosis. Now, just lateral to the left lateral to the midline, there may be palpable aorta, abdominal aorta. Now, I am feeling Shafiq's abdominal aorta, but his aorta is very strong, just the smallest size, I think, 1.2 centimeter to 2 centimeters. So, if there is abdominal aorta aneurysmal dilatation, we call it AAA, abdominal aortic aneurysm. In that case, if we listen here, we can hear the aortic bruit. Okay, that's all. So sometimes we can listen to the femoral artery bruit as well. Okay, that is the auscultation. Now, to end up abdominal examination, I have to expose the external genitalia, examine. So if there is something abdominal mass and so on, it may be due to undescended testes. So we look at examining the testes, absence of testes. So possibility of undescended testes with testicular tumor intra-abdominally, something like that. Otherwise, according to the finding, we'll do the hernia examination and so on. As well as now, to end up, we have to do PI examination. From the PI examination, okay, done. Usually, PI examination with our mannequin here, we set up 4 prostates. So third prostate is the best. So it has got left on the right lobe of the prostate, there is a hard nodular mass, 2 centimeter by 1 centimeter. So that when we do PI examination, left lateral position, and we will feel, first of all, presence of median sulcus present, I can feel. Next, feel the 2 lateral lobes. Another one that status is we are going to give the scenario to do PI examination. 70-year-old man with presence of 2 weeks history of hematuria, painless hematuria. So we asked to do PI examination. By that time, can feel the prostate, okay, median sulcus is present, but there is a hard nodular mass on the right lobe of the prostate. So we will ask you, what was the disease? The student can answer, it's a cancer prostate. So we can ask, how will you confirm this cancer prostate? By doing needle biopsy. Okay, there you look for the Gleason scoring and so on. So that's how we got, so this is completing abdominal examination. Okay, everyone, I think you all can enjoy watching today's my demonstration of abdominal examination in UniKL RCMP in our clinical skill lab here. Okay, thank you everyone. Bye bye. Okay, observe all my videos from YouTube video. I uploaded about 15 programs already. That is Dr. Tewin's examination. Another two are Dr. Tewin's exercise, and another one is Dr. Tewin's piano playing. I think you all may enjoy watching all those. Thank you very much, everyone. Bye. Okay, say bye bye. Bye bye to everyone. Okay, done. Thank you. How long is it?